Hopefully everybody can see these slides. This is all the standard information. If you have any questions about CMEs or CEs, please reach out to Rana and she can assist with that. I have nothing, neither myself or any of the presenters today have any financial relationship to the content that we're going to discuss. I'm going to share some information about how important it is to consider including and incorporating family intervention into the work that you do with individuals with substance use disorder, and how we call them in the field, because I'm going to talk a little bit about how family is defined, is CSOs, or concerned significant others. So how do you involve concerned significant others and families into the work that you're doing? So I'm going to talk a little bit about some core concepts and why it's part of best care for working with the substance use disorder population, discuss how important that is and ways that you can use it as part of kind of your strategic intervention. And then I'll wrap up with some ideas or methods that you can use to incorporate family without providing actual family therapy. So I'm not going to talk about family therapy today, but just talk about ways that from a broad stance, you can incorporate family and CSOs into standard practice and begin to think about them as part of that extended treatment team. So let's define what is family. So within SAMHSA or NIDA or any of the major organizations that look at the importance of family intervention, they encourage defining the term family really widely. So family really is anyone in the patient's social life that there is some sort of enduring or significant tie. So how they define the word family is what's most important. So you can start by saying, who is most important to you right now? Who would you like to be involved in your care? Who could be involved in your care, right? So that could be a number of individuals. It doesn't have to be somebody that they're actually living with. They could live apart from them, as long as there is that connection. This isn't somebody that they haven't spoken to in years, but there is some sort of actual interpersonal connection there. So populations that you could consider when trying to identify who a CSO might be, or additional CSOs, that could be parents, grandparents, guardians, romantic partners, spouses, could be in-laws, siblings, children, godparents, extended friends, or family, even colleagues or coworkers, right? So it could be really broad how family is defined, but thinking creatively that there has to be, likely there is, I don't say there has to be, but likely there is somebody that has a connection to this person that would be willing to be involved in their care. Why is this important? Because that network, that social network that the individual is living in, their addiction is going to be related to what's going on in that system, and is going to affect that system. So addictive conditions really affect an entire a working system, however that is comprised, and it puts a tremendous amount of stress on that family system that can lead to negative feedback loops, where our patients have really difficult interpersonal interactions or experiences that can then become significant triggers for relapse or ongoing use. The other thing to keep in mind is that oftentimes substance use does not develop within a vacuum, that in fact it develops within a family system. And so when you get to know a patient, you get to kind of know that system in which they're coming from or they're currently existing, you can begin to see a number of negative coping strategies have been employed, or unhealthy coping strategies, in order to kind of maintain the system as a unit. And so as patients enter treatment and start to get better, that can actually threaten that family system in an unhelpful way. And so family members or CSOs don't intentionally necessarily mean to disrupt somebody's recovery, but that can be what happens at the end of the day if we're not actively working to incorporate them in the care plan and make sure that they're aware of what is best for that patient and that communication is ongoing. Addiction can cause tremendous emotional distress within a family system where a lot of anger and resentment can build up over time. So what happens for folks by the time they get to specialty care, by the time they enter treatment, their families have often exhausted a lot of merit. And so there tends to be a fair amount of broken relationship or resentment present. And so encouraging some of that bridge building as part of healthy recovery can be important. The other thing to understand is that family members or friends, however they're being defined, CSOs, will take on a fair amount of responsibility for the identified patient. And that can come with their own experience of depression or grief, guilt, or shame. And that can really be problematic for building those bridges and encouraging long-term recovery. Another factor to consider here is that addiction oftentimes crosses generations. So people that are experiencing addictive conditions oftentimes have that within their family system or have come from that. So when we're working with an individual, we're working with both their history and what has led to their present presentation, but also the relationships that they have with their children or the children in their life, because that's going to affect that future transmission of the addictive condition. And so that's another reason why it can be really helpful to bring in some of those supports to make sure that the children that are present in the lives of the patients that we're treating are maybe less affected or less vulnerable, because we know that about 70% of abuse and neglect cases will involve some level of substance use, that substance use in the home likely will interrupt normal childhood development and will lead to higher risk for physical, mental, and emotional problems for that child. Lots of issues with school, with peers, higher incidence of learning disabilities, of skipping school or being expelled, and having mood, oppositional, medical, attentional, or executive functioning issues, and then be 4 times more likely to develop substance use disorder themselves. So you can see how the person sitting in front of us is likely somehow connected to some of those unhealthy patterns and may unintentionally be contributing some of those unhealthy patterns to the children in their lives. And so being able to have a conversation like the case that was presented a couple weeks back about the role that parenting can play in terms of healthy recovery, being able to help them understand if you continue on this really positive journey, that's going to have really positive impacts on the lives of your children, not just to prevent your own death, but also to prevent a whole host of negative outcomes by removing addiction from that cycle. So understanding that the family is a system, that it really is more than just a collection of individuals, that it is an organic whole that really has its own identity and dynamics. You also have to understand that every member has a specific role or function within that system, and they may not play that same role in isolated periods of their life. So when you're working with somebody on an individual one-on-one basis, you're only seeing one slice of them, versus if you're able to bring in a CSO or work with a CSO in tandem, then you can sort of see how is that behavior functioning within that system, and where are there potential opportunities for intervention that individual may not be able to implement on their own because it's going to be a challenge or it's going to be really difficult within that present system. Family relationships or the role that CSOs play is really, really vital in the sense that it is bi-directional. So they tend to be a principal source for both mental health and psychopathology. So that means that unhealthy systems really hurt people and healthy systems really help people. And in fact, the majority of people that don't need specialty care, that are able to deal with their substance use issues without higher levels of intervention, one of the variables that shows that they're able to do that is because they have healthy functioning social networks. So they're able to reach out to that social support and get that social support. And so the patients that we're working with, 9 times out of 10 do not have those healthy relationships and will need some redirection or intervention to create a healthy interaction for recovery to flourish. And we already talked about how family patterns will tend to repeat across generations. There's both a genetic component to that, but there is also a social modeling or social learning component to how we see that same set of behaviors sort of repeat from generation to generation. And so what we're trying to do by engaging with CSOs is to really strike that balance between how do you have the support that you need, the connection that you need, but not be so entrenched in the system, particularly if it's not necessarily the healthiest system, or there's a lot of negativity, a lot of hurt, a lot of trauma that's in that system that you don't want to be so close to that you're at risk for continued abuse, continued triggering that's going to impact your use disorder. So how do I have the connections that I need in my life so I have just enough support, but also have that level of individuation and autonomy and agency that I can continue to make healthy choices and decisions, even if that stresses or sort of upsets the current status quo. And then making sure that we're always understanding, again, the person that we're meeting with one-on-one, we're only seeing one slice of them. So if we have a better idea of what's going on in those family interactions, we're also going to have a better idea of how that's going to translate to things like work or school or other domains that are really part of healthy recovery. So what does that mean? That means that we really do need to treat the system and not just the individual. And that's why the number one recommended intervention for individuals with substance use disorder is family therapy. That doesn't mean that you as a prescribing provider need to provide that family therapy, but to be able to make a referral for that, absolutely. To be able to include a CSO at the level of care that you are providing, to bring them in in some shape or form and not exclude them is really important. And I think, unfortunately, there's been a large movement over the course of substance use disorder treatment to really further isolate individuals because of that fear that their use disorder is going to further stigmatize them. We've really put a lot of barriers to connecting with CSOs and family. That being said, even within HIPAA, even within 42 CFR, there are lots of ways that we can get releases of information. We can get permission from the patient. We can give them a clear explanation and rationale why we want to bring a CSO in, and we can include that into the course of care that is both allowing us to protect their privacy, but is also helping us to really employ best practice by involving that family system. So when we're working to look at that, we want to understand a lot of different things, right? How does the substance use presentation, how does that potentially reflect other difficulties that might be going on within that system? Is the substance use disorder maintained or exacerbated by those family interactions? Are there family interactions that could potentially be repaired to decrease the likelihood of triggering or maintenance of that use disorder? Or are those family interactions really so difficult that we want to encourage more on the side of autonomy and shifting away from time and having more space with those family members, because there isn't going to be the opportunity for the kind of repair that's going to support recovery. The other thing to keep in mind, and you guys probably see this in a lot of your practice when you get a good history, is that adults with substance use disorder are 5 times more likely to live with a parent or family member who raised them, grandparent, guardian, aunt, uncle, cousin, something like that, from their family of origin. That has major implications that if we're not attending to, could really disrupt long-term recovery or even keep people stuck in the short term, because if they're living within that healthy system now while they're trying to make improvements, if we're not addressing that or trying to intervene in some way, we're really kind of in a losing game, because that's their current state of support. Individuals who seek specialty substance use disorder treatment oftentimes come in pre-contemplative, which means that they're coming in under the behest of family members, and there could be some level of coercion there, like you need to get better or else. And so if we're not reaching out to that CSO or that family member, there could also be some disruption in misunderstanding ongoing use or misunderstanding relapse, and how we can help them work through that effectively to maintain that connection could be really helpful if we have that communication in place. And then recognizing that families will sometimes inadvertently sabotage a patient's treatment progress. And that's, again, it's not because they want the person to continue to use, but there are things going on within that system that that sort of maintain that patient's use or that patient's role within the family as the user or the black sheep or whatnot, that if you could bring out, if you can call that out, you can sometimes work through that in a really positive way. Versus if you have no contact with that family system, it's going to be really hard to help them identify that sabotage is occurring. And so following that, sobriety can really impact a family system. And they may not be prepared for how it's going to impact them. So being able to provide some education at those time points can be really helpful. The other thing to keep in mind is women and adolescents with substance use issues are really do need to have some level of family intervention connected to that. So why is that? It's because these roles in particular, a lot of the substance use manuals and protocols that have been developed over time were developed on male patients. And so we're starting to see that that's not always appropriate for women and adolescents who are highly connected to their children and their families of origin. And so we need to understand that and be sensitive to that and work to incorporate those very important systems into the treatment that we're providing. So that being said, why don't we do this more routinely? There's a lot of barriers to family involvement. There's a lot of both client barriers. We have patients that feel tremendous guilt and shame over their use behavior, and they may not want to bring that into the room. They may have certain unhelpful or unrealistic beliefs, like saying it's my problem, I should handle it myself. I'll bring them in when I'm better, like those types of beliefs we hear a lot. They don't want their family to know about their current use. So being able to explain, we're not going to talk about your UAs, we're not going to talk about your current use, but we're going to talk about maybe some education on opiate replacement, that it is not just substituting one drug for another, or bring them in and we're going to talk about what does the course of care look like, about how long are you going to need to come and see me, what other types of services would be helpful for you, like those types of things. You can clarify. We don't necessarily have to talk about your use. And then family members themselves can have a lot of that frustration in having tried to help in the past, that feeling of powerlessness or inability to have help, and then their own guilt or shame because they haven't been able to do anything up until now. But most of the time, in my personal experience, the main barrier for family is that they just haven't been invited, that we haven't reached out to try and engage them. There are, of course, staff barriers. So it could be that staff feel unqualified, is really complicated and messy to involve CSOs and family members. May feel that it's going to kind of worsen, or it's going to be too difficult, or that the family doesn't live in the area. And now with Zoom, with phone technologies, we can obviously kind of bridge that barrier. And then there are facility barriers, right? That facilities or programs may not provide enough space, enough funding, enough materials, enough time for staff to have those collateral contacts, right? There are some billing codes that can be employed when a family member is present, but unfortunately, a lot of the work that has to be done to engage with family or CSOs are phone calls and sort of case management pieces that aren't necessarily going to be covered by that particular service. And so if you have an agency or you're in a position where you don't have that space or that time allotted to do that as part of routine treatment, that can be a pretty significant barrier. So what are some things that you can do? Well, keep in mind, you don't have to necessarily reach the entire family, that the data is really clear. Engaging even just a single family member or concerned significant other. Remember, they don't have to be biologically related to the patient, but however they're defining that CSO, engaging just one of them can significantly strengthen that entire social network, that entire system, and reinforce and motivate the patient so that they can stay engaged in recovery. And we know that the longer that they stay engaged in the recovery process, the more likely they are going to have a positive prognosis and positive outcome from those interventions. So how can you get them involved? You can get them involved on multiple levels, not just traditional family therapy. Some of it can be as simple as just bringing them in or having a brief phone call to teach them about the program that you're providing, about addiction in general, about the recovery process for addiction, that there is hope. You can have them participate in intake. You can have them participate in treatment planning. You can even have them come and share in certain psychoeducation groups or different lessons where you might be going over psychoeducation. So if you're teaching a skill to the patient, why not have the CSO in the room so that they're both learning it and that the CSO can reinforce that at the same time. Even having things like separate family orientations or family appointments when appropriate to be able to provide some really targeted education to that CSO, and then encouraging them from sort of a non-judgmental manner, that we're not going to dig into the history. We don't have to go down that road. If you guys want to do that, I can help with a referral for formal family therapy or couples therapy. But for this, we just want you to be involved at whatever level you are comfortable being involved in. There are a lot of really great books that you could refer. So at a minimum, being able to send some of these resources home. And I know in the past, Dr. Salvador has had some funding available to provide some of these materials for folks. So you may reach out if some of that may be available. The Beyond Addiction book is a really wonderful guide for families, and it aligns beautifully with craft and CBT and a lot of the interventions that are recommended for the individual. And it helps family members see what they can do, what they can't do, and support them in that process. So How Science and Kindness Help People Change. It's a wonderful book. But studies have shown that there's, in general, much better treatment engagement when a CSO is involved, 64 to 74%, depending on the intervention, that there's better retention and treatment completion, about 77% across studies, and that we see improvement in family functioning, problematic behaviors, and substance use when CSOs are involved, and that there are actually effective evidence-based treatments that you can refer patients to that want to have a higher level of involvement with their CSO, such as CRAFT, CBT, IPT both have family pullouts. The Matrix model has a family pullout. Of course, there's things that can happen in the home, like the systemic family therapy, brief strategic family therapy, and so on. So things that you can do outside of those formal referrals is just recommend, that individual and family piece as part of routine care. Provide psychoeducation, workshops, orientation groups for family members if that's something that isn't already happening. Sometimes at a minimum, just allowing access to Narcan or training on Narcan can be really helpful, a really important way for bridging with CSOs. Making sure that you have a list on hand for family support groups, NAMI online support groups, other things that could be provided for family members that are struggling. Even things as simple as offering to provide a tour of the facility so they can see where their loved one is receiving care, so they know when they're there. Inviting them to be part of that first appointment, of course, with their permission, any treatment planning appointment, psychoeducation appointment, and then offering a connection. If you have a question, feel free to call our clinic. We'd be happy to answer that for you. Obviously, you're not going to provide specifics about the patient's care, but general information about the clinic, about the program that you're running, the services that are being provided. And then other things that we've done that have been helpful for bringing them in for like orientation groups or craft groups is to see if local businesses or others can donate small prizes or different items that you could raffle at the end of that group, so that there's sort of an incentive in place for CSOs who may be a little resistant to want to come in. Other things to consider, because oftentimes families are working, thinking about the times in which you make these things available. Would it be possible to have a once a month family orientation that occurs in the evening, or maybe even on a weekend time? Creating sort of this philosophy of care where we're open to CSO involvement and we routinely ask about it and encourage it. So really that being adopted as part of the philosophy of the program that you're providing. Working with them to really understand where each other are coming from as part of that educational process. And then letting family know that they are important and that they can still make a really big difference. And maybe their efforts weren't successful as a standalone, but that doesn't mean that they couldn't be part of their loved one's success at this point. So letting them know during those time points how they can get involved and how they can be of assistance, and then just respecting if they say no. So if family members don't want to be involved, that's okay too. We recognize that there may be a lot of hurt and pain there, and now it's just not the right time. But you keep asking, right? You ask when it's appropriate, and work really hard not to use some of the old language that comes out of substance use literature, such as labeling family or identified patients as resistant, codependent, enabling. These are really out of date labels. They don't have a lot of research to support it. And they're just in general unhelpful. So trying to kind of give people the benefit of the doubt, start from fresh. If people will come to these educational opportunities, think about it as an opportunity to teach and collaborate with CSOs who are willing to be there whenever possible. And just in general, kind of being flexible for that. Keeping in mind that the 4 factors that really influence recovery are what we're doing to support health for our patients, what we're doing to provide a safe and stable living environment, what we're doing to increase purpose. And this is where CSOs can really have a big part to play. Families that can support this kind of why are you living your life? What is it that gives you meaning? And then connection to community, another area where CSOs can really have an influence. So all 4 of these domains are something that CSOs can be part of supporting with the patients that we work with. And here's some references connected to everything I just shared. So I will